Good morning, everyone, and welcome to our presentation on biofilm. What is it and why do we care? There are 6 parts to today's presentation. Firstly, we will talk briefly about our literature search for this presentation. This is followed by an introduction to what biofilm is and its role in wounds, particularly in the chronic non-healing wounds of the high-risk foot, its implications, and the management and treatments of such wounds. Finally, clinical case studies that are relevant to the presentation will be discussed.
Through searching for and acquiring our articles, we went to the La Trobe University Library website. We chose podiatry-specific databases such as CINAHL, Cochrane, and Medline. As this is a broad assignment on what biofilm is and why do we care, we decided not to condense the search terms and decided not to omit any specific level of evidence. And we tried to include a broad range of evidence levels as stated by the NHMRC hierarchy.
What is a biofilm? A biofilm consists of a community of bacteria attached to a solid surface to form a layer of slime of a few to hundreds of layers of cells. It can consist of more than one bacterial species. The bacteria are encased in a polymeric extracellular matrix or ECM, which acts as a protective barrier around the biofilm. As you can see, the picture on the right shows a Pseudomonas aeruginosa biofilm in a diabetic wound. Notice how the bacteria is surrounded by a protective layer of ECM. Importantly, the bacteria in a biofilm are highly resistant to antimicrobials and are able to evade immune responses and desiccation. As a result, it is a cause of many chronic infections and diseases. However, why do bacteria want to form a biofilm? According to Jefferson, there are 4 main reasons. 1. To protect the bacteria from the harmful conditions in the host that threatens its survival. This includes shear forces due to blood flow, nutrient deprivation, and the host's immune response. To maintain a favorable habitat for reproduction. There is simply strength in numbers. The bacteria are able to utilize the benefits of being in a community. And lastly, the bacteria are just being themselves. The bacteria that forms biofilms usually reproduce as biofilms as their default mode of growth. So, how do biofilms develop? Biofilms develop in 5 stages. In stage 1, the bacteria reversibly attaches to the surface. In this stage, the bacteria can be removed by shear forces such as those arising from blood flow. Stage 2 is the irreversibly aggregation of bacteria. In this stage, the bacteria cannot be removed by shear forces. Stage 3 is the maturation stage whereby the bacteria aggregate starts to form layers. Bacterial layering continues in stage 4. Finally, in the last stage, after forming a biofilm, the bacteria disperses to distal sites to establish new colony or infection. Interestingly, biofilms can be found everywhere, even in the most extreme of conditions. It is ubiquitous in nature such as in soil and rocks and in industrial materials such as water systems. They can also be found in biomaterials and implants in the human body such as intravenous central lines, prosthetics heart valves, catheters and contact lenses, the gastrointestinal tract and teeth surface. More importantly, and of relevance to our presentation today, biofilms are extremely common in non-healing chronic wounds such as diabetic foot ulcers.
The presence of biofilm in wound greatly impacts the ability of wound healing, and this can be detrimental to the high-risk foot population, such as people with diabetic foot ulcers. Not all infecting microorganisms will result in biofilm-producing infection. A study by Malik et al. Found the overall biofilm-producing infection rate among the diabetic foot ulcers to be 67.9%. There are various significant risk factors associated with the presence of biofilm in diabetic foot ulcers, such as durations of diabetes, duration and size of ulcer, previous antibiotic use, male gender, subcutaneous and polymicrobial infection. Finally, a conclusion was drawn that the presence of biofilm is likely to result in chronicity and complication of the wound, as it represents a barrier to treatment and healing of the wound. Infection in diabetic foot is common and could have severe consequences if not treated appropriately. A review of literature by Richard et al. Found that various pathological changes which accompanied diabetes resulted in disturbances of host-related factors in diabetic foot infections. Immunopathy, which involved altered functions of polymorphonuclear cells and overall defects in host immunity, was observed in diabetic patients with poor metabolic control. Impaired functions of monocytes and macrophages had been documented in diabetic patients and was thought to decrease bacterial killing capacity. Diabetic neuropathy affects both autonomic and sensory motor systems. This could lead to anhidrosis, which increased likeliness of fissures and cracks, loss of protective sensations, and impaired neurological inflammation response. Diabetic angiopathy could lead to peripheral arterial disease and microangiopathy, which leads to ischemia. Ischemia was found to delay wound healing and increase risk of wound infection by twofold. The pathological changes in diabetic population increase the risk of infection and reduce ability to facilitate healing in diabetic foot ulcers. Biofilm can form within 24 hours and could be visualized at the capillary membrane of peri-wound vasculature, which was well perfused. The host immunity was less effective against invading microorganisms due to presence of biofilm as found by Walcott et al. The same study was reported that the community of microorganisms can develop defense against host immunity through combined genetic potential to produce clinical biofilm infection. Nguyen et al. Found dysregulated inflammation and immune response in diabetic wound with biofilm. Expression of biochemical markers of inflammation and immune response was significantly reduced. This suggests impaired recognition of infection and inadequate inflammation response to an infection by the host, which may prolong healing time and increase susceptibility to infection. It is important that the presence of biofilm infection be identified quickly and accurately. Percival et al. Documented pale wound bed, yellow discharge, necrotic tissue, clear slime, putrid smell, friable granulation tissue, red wound bed, biofilm forming bacteria cultured from the wound bed as the clinical marker of biofilm. The concept of functional equivalent pathogens proposed by Dow et al. This concept suggests that the individual member in the community may not cause disease. However, as a community, they display functional equivalents of well-known pathogens such as Staph aureus. This highlights the limitation of traditional culturing methods as a diagnostic tool, as they tend to isolate easily cultured organisms such as Staph aureus.
Biofilm plays an important role in wound colonization, infection, and non-healing because it is able to produce quorum-sensing signaling molecule which allows it to communicate within the cell. It is able to grow, mature, and protect itself. Once established in the wound beds, it is highly tolerant to removal and eradication. It causes failure of the wound to heal and causes chronic inflammation by inducing perpetual inflammation within chronic cases and increases its susceptibility to infection. Its effect shows that it increases its resistance to antimicrobials, immunological and predatory and chemical attacks, which renders traditional antibiotic methods to be effective against it. Venous leg ulcers, pressure ulcers, and diabetic foot ulcers develop, degenerates, and worsens, and eventually leads to amputation due to impaired wound healing from biofilms. It has been shown that biofilm has an important influence on how quickly a wound can heal. In acute wound cases, it generally heals within 2 to 3 weeks, while chronic wounds can stay open even after 2 to 3 months. Other implications that biofilm have upon include cystic fibrosis, otitis media, dental caries, periodontal diseases, and prostatitis, as well as being the cause of acute infection and dwelling in medical devices, which increases infection to other patients. As mentioned by Percival 2012, the signs and symptoms are pale wound bed, a yellow discharge, necrotic tissues, a clear slime, putrid smell, friable granulation tissues, and a red wound bed are how biofilms may manifest itself, and it is vital to identify it, manage it before it takes hold, establishes itself, and becomes harder to remove.
Biofilm management strategies. Management of biofilms can be difficult. From the research, there are two streams of thought that can be used to treat wounds with biofilms. There are mechanical strategies or anti-biofilm agents. These are usually used in combination with each other as well as other fundamental wound bed principles such as mechanical strategies to achieve a healing Mechanical strategies involve the physical removal of the biofilm itself, and this has been reported to be highly efficient and cost-effective. The removal of a biofilm in a wound can be achieved through regular scalpel debridement, ultrasonic debridement, and any other removal of dead or necrotic tissue. In biofilm management, the principles of wound bed preparation should be employed here to help the wound heal. Such procedures as regular debridement and cleansing of the wound, microbiology samples, assessing the patient holistically, and regular reviews of the wound should be practiced. Anti-biofilm agents. In a case series by Newitt in 2011, it was stated that both systemic and topical antibiotics alone are unable to eradicate biofilm infections. Therefore, they must be used in conjunction with each other. So, for example, a topical antibiotic at the site of infection alongside a systemic antibiotic. In an article by Davis, there are 5 ways to prevent, reduce, or treat biofilms. They are preventing the bacterial attachment of the biofilm, preventing the formation of a biofilm, disruption of the biofilm to allow penetration of antimicrobial agents, interfering with the quorum sensing, and enhancing dispersion of bacteria from the biofilms for it to be destroyed. There are an array of medicaments, all aimed at achieving either one or more of these strategies. For example, lactoferrin impairs the attachment of the biofilm to the wound bed.
Now we will be looking at case studies. In the article by Newton colleagues in 2014, it looked at biofilms in the chronic diabetic foot ulcers in 2 cases. The first case involves a 55-year-old male with a 14-year history of type 2 diabetes. He presented with a non-healing ulcer on the superior aspect of his left hallux. He was treated with multiple courses of antibiotics, a total contact cast, which was followed by rigid orthopedic shoes, and he required multiple debridements. After 7 months, an amputation was performed. In the second case, a 69-year-old male with type 1 diabetes presented with a non-healing ulcer on the medial plantar site of the left foot. He was treated with antibiotics for 6 weeks, a total contact cast, and multiple debridements. After 6 months, surgical debridement was performed. Soft tissue samples were taken from both patients in the operating theatre. The first patient's wound revealed multiple species making up the biofilm covering the wound, and the second patient's wound revealed 2 different species making up the biofilm covering their wound. Both patients had Staph aureus present. This demonstrates that a well-developed mature biofilm can adhere to the soft tissue, not just in the context of a foreign body or dead bone. This can also show that the infected diabetic ulcers act as a reservoir for pathogenic biofilms. Often ulceration in the diabetic foot is partly caused by vascular insufficiency, which can lead to limitations when trying to address infection with systemic antibiotics. Furthermore, the antibiotic resistance of biofilm bacteria is up to 1,000 times greater than that of planktonic bacteria. It is shown that the use of systemic and antibiotics together are not enough to treat biofilm infection, and it is advised that they must be used with a topical antiseptic and the anti-biofilm strategies discussed earlier in this presentation.